All right. Well, thank you guys for joining us tonight. I hope everyone's had a chance to get a bite to eat, or at least is taking a bite to eat right now as we get started. I want to welcome you to our peer-to-peer conversation led by Dr. Elisabeth Poorman, speaking on trauma, depression, COVID-19, and other occupational hazards of medicine. Our event tonight is sponsored by the St. Luke's Community Health Improvement Fund. We're really grateful to them. They've given us several grants over the years for high school physicals, suicide prevention, and other projects that we've had. So we're really grateful to be able to use their funding on our program tonight. So with that, I would like to introduce Dr. Andrea Christopher, who is a friend of our speaker, and she is going to introduce Dr. Poorman tonight. So Dr. Christopher, take it away.
Thanks, Steve, for giving me this opportunity, inviting me to introduce Dr. Poorman. Even though I didn't get to be involved originally in the setup of this, it's a pleasant surprise for me to have a friend and colleague coming to our community to speak today. I'm going to start with the professional bio. So Dr. Poorman is a general internist and currently an addiction medicine fellow at the University of Washington. She completed her medical school training at Atlanta, and then went on to complete residency at the Cambridge Health Alliance in Cambridge, Massachusetts, where she was practicing as a primary care physician before coming to Seattle. In addition to her clinical work, she is an accomplished writer and well known as a speaker as well, speaking and writing about her experiences with mental health treatment and medical training, and also publishing academic and lay press articles about depression and suicide risk as an occupational hazard of medical practice. She's also published dozens of widely read articles on how to provide ethical care in a deeply dysfunctional healthcare system, and has spoken at medical school programs, residencies, and hospital systems across the country on the importance of mental health access for physicians. I must also pause to give my kind of personal friend intro. I first met Dr. Poorman when I was a research fellow and she was in her residency training program. And I was really struck by, one, her incredible skill at considering disparities in access to care, and research we were in the same research group, which is how I first got to meet her. And then over the years have been able to have some really beautiful conversations around mental health, both in sort of my own experience and with friends, and getting advice on how to navigate different situations. So I'm really excited to be able to have her here today. And I must take a moment to acknowledge her greatest claim to fame, as far as I'm concerned, is when Lin-Manuel Miranda retweeted one of her tweets, which feels very important. Okay, without further ado, Dr. Poorman.
All right, everybody. Well, I'm so glad to be here with you today. I wish it could be in person, but I think I want to thank Andrea and Steve and everybody at Ada County Medical Society who's really put a lot of thought into how to make this as warm and interactive and supportive as it possibly can be. So I am going to go ahead and try to share my screen here. And let's see. All right. And if you could just tell me in the chat, everybody able to see that?
That looks great.
Great, fantastic. Okay, so as Steve said, and also if you want to leave your video on, that's totally fine. If you feel more comfortable having it off, that's fine as well. We in the breakout rooms are going to ask you if you can to put the video on, but I understand we're all sick of looking at ourselves on screen, so no pressure during the talk. And if you have questions, concerns, comments, feel free to write it in the chat. Steve is going to be monitoring that during the talk. So as Steve mentioned, my talk today is depression, COVID-19, and other occupational hazards of medicine. I have no financial disclosures, and I want you to know that this talk does bring up a lot of personal, sometimes painful issues for people. And it's really not uncommon for people to reach out to me afterwards if they want to talk through a particularly difficult situation for themselves, for somebody else that they're concerned about. I'm always happy to get those emails. So that's my personal email. If you want to see more of my work, probably the easiest way is to just follow me on Twitter. And I also have a website link there. So I'll start my talk today the way that I always start my talks, which is to let you know that this is a personal issue for me. I experienced my first episode of major depression when I was an intern. And, you know, my symptoms were pretty classic. I was sad a lot of the time. I didn't find pleasure in a lot of things. I found it difficult to sleep on my days off. And I was really overwhelmed with the suffering of my patients and the very limited number of things that we could do for them. So as Dr. Christopher mentioned, we were both at Cambridge Health Alliance, which is a wonderful institution that serves a very poor and at-risk population. And, you know, there's a lot of things that medicine can't fix. So all of those things were kind of quite overwhelming to me, but it was quite clear to me kind of early on that I was depressed. And what was really strange to me in retrospect and concerning to me in retrospect was that when I reached out to colleagues, both at my program, friends at other programs, and said that I thought I was depressed and needed some treatment, the response was, "Oh, you're not depressed. That's just medicine. Everybody's miserable. And we just have to, you know, kind of grin and get through this." And I thought it was such a strange response. And I kind of sensed underneath it also a kind of fear of calling this depression and a fear of what treatment would actually mean. But I did actually seek out treatment. And unfortunately, because of the insurance that I had through the institution, I was only able to see somebody who actually worked very closely with many of my colleagues and whose office was in the same building as my program director. So I would be going in on my day off to therapy, trying not to run into anybody. And I really just didn't find that therapeutic. And I had a lot of concerns about my privacy. So I stopped going. And I thought, okay, well, maybe this will just get better. And it didn't. It got a lot worse. And then towards the end of intern year, a psychiatrist that I was learning from actually reached out to me and said, you know, you really seem to be struggling. Is there anything I can do to help? And I told her, you know, I'm not doing well. I've actually tried to get treatment. It wasn't successful. I don't know where else to go. And she gave me a list of therapists in the community. And I found one that I really clicked with. And it was amazing. After a few sessions, I really felt a lot better. It was like a cloud of gray had totally lifted off of my life. And so at the end of intern year, I was visiting a friend at NYU Medical School. And I thought, okay, I've been through this episode. It's clearly something that people are not comfortable talking about. I internalized that this was considered to be some kind of sign of weakness. And so I thought, okay, I've been through this. I'm better. I'm just never going to speak about this again. And then like this new crop of interns is going to come in and I'm not going to tell them anything. And it was a beautiful sunny day and we were walking back and I was just, you know, feeling really excited about the rest of residency. And we were walking back to her dorm and we were stopped at the door and told that we couldn't go inside. And the reason we couldn't go inside, we found out later, was that a young man who himself was just a few weeks into his intern year had gone to the top of the building and jumped to his death. And he was one of 3 residents who killed themselves in exactly the same fashion that summer in New York City. And I knew then that silence just wasn't going to be an option for me. When I talk about this topic with other physicians, I'll often get answers like, You know, you guys early in practice, I mean, I'm not as young as I used to be, but you guys really seem to have a lot of issues with mental health. You guys seem really to be depressed. That's not something that we experience. And then by the end of the conversation, they'll be like, well, I guess I was pretty depressed in residency, or I was really depressed in my intern year. And this quote, this is from Dr. Matt Watto, who is one of the hosts of the Curbsiders, was gracious enough to have me on his podcast a few years ago to talk about this topic. Told me, you know, I haven't really been depressed, but especially in my early career, when there'd be like a train coming by, I have thought, you know, I would never kill myself, but gosh, if something happened, it would be so much easier. And then what this tells me as a clinician taking care of other clinicians is that the signs of suicidality, the signs of depression in doctors may be quite different. We tend to minimize, especially mental health concerns. And two, that we don't seem to be that aware of how well or not we're doing. And it also rings really true to me after speaking to some people who have survived suicide attempts. It doesn't tend to be a long planned out thing. It's kind of an impulsive act. So I think that's why it's just so important for us to bring some attention. So today what I'm going to do is I'm going to argue that depression and suicide are occupational hazards of medicine. And the reason why I think that this framework is important is that it first helps us to recognize the scope of the problem, and secondly, helps us to think about a framework to mitigate these hazards. We're going to touch briefly on the additional stressors of COVID-19, and I hope that you guys get into this more into the breakout session. And then most importantly, I want to ask and learn from all of you about what your experiences are, what you think we can do as individuals, as a national professional culture, and especially locally in Boise. So a lot has been made of the idea that physicians might be at risk before they start training. But it's important to remember that before medical school, that medical students are healthier than their peers, right? And that makes sense. We're selecting for people who have been successful, oftentimes people who have the kind of enough resources and wealth or support that they can delay making money for a while, and people who may have, on the whole, had fewer adverse events in their lives. But what happens in medical school? So in medical school, things get a lot worse, such that 1 in 4 medical students reports that they are currently depressed. And 11% of medical students say that they have contemplated suicide in the last 12 months. But in spite of that, and in spite of the severity of this issue, only 1 in 6 medical students with depression say that they have sought help. Now, why would that be? If you want to venture any guesses in the chat, why would it be that medical students who are presumably at a hospital, surrounded by other physicians, have plenty of access? Why would they not be accessing care? Yeah, and so Mo is guessing stigma and denial. Sharon says lack of privacy or fake privacy. I like that term, fake privacy. I'm going to steal that. Yeah, absolutely. And the most common reason cited in this study was that students were afraid that this would have a negative impact on their career. So what's happening in medical school is that, one, we're experiencing depression or other mental illnesses, a lot of cases for the first time. We're learning about these mental illnesses. We're being told that they're important to diagnose and treat, but at the same time, we're getting this message through, culture and informal talks with each other, something that people call the hidden curriculum, that tells us that it's not acceptable for us to have these mental illnesses, and it's certainly not acceptable for us to ask for help. But luckily, things do get better in medical school. As we reach fourth year, as many of us are going to be accepted into residencies, such that when you test people right before intern year starts, only 3.9% of them are going to meet criteria for major depressive disorder. But what do you think happens in intern year? You can put the answer in the chat. Do you think things get better, worse in intern year? Do they stay the same? They get much worse. Yeah, I think Mo probably has experience seeing that. Things do get much, much worse. So the reason we know that is that the best study that was done on physician health is the intern health study, which actually followed 700 interns in different programs throughout the country, throughout their intern year. And yeah, and Becky says that things get worse, resources are drained, absolutely. So we start with 3.9%. By the end of intern year, at one point in time, 41.8% will meet criteria for moderate to severe depression. And that's just an intern year. Oh no, I've made a little spot. So in other words, we're gonna have a 10-fold increase in moderate to severe depression in the first year of training alone. What happens after residency, we don't exactly know. We do know that physicians in practice do report that they have depression at rates that are higher than the general population. But as we talked about, physicians don't tend to be great at recognizing their own mental health state, and that's actually been shown in other studies. But we know at least that they're reporting depression rates higher than the general population. And we know that the rates in practicing physicians never return to the pre-training baseline. So something happens in training and it has lasting effects on us. So if I could just pause first, anybody know how to get rid of this? This green thing is driving me crazy. You can tell me in the chat. But in any case, if I could just pause and kind of thank you so much and go back and summarize what we've been talking about in terms of the life cycle of depression. So we start medical school and we're much healthier than the general population. And then we have our first big peak in medical school, probably peaking around third year. Then things get a lot better as we near graduation, right before we start intern year. And then in intern year, we have our biggest spike. Now, we don't know exactly what happens in the rest of the training because that intern health study didn't continue and there haven't been longitudinal studies throughout residency, but probably things stay similar, maybe get a little bit better as the adjustment goes on, but most likely the rates are still going to be quite high. And then after training, things do seem to get better, although, as I said, the data is less good, but things still remain quite serious. And our rates of depression are about double the general population, and they never go back to that pre-training baseline. Okay. And then Sarai asks, are these PGY ones that match their first go? I don't think that was asked in the study. So all of that to say is that depression is an occupational hazard of medicine. And it's not just depression. So other things are also going to be quite elevated for us, including substance use disorder. So 1 in 8 male physicians actually, when you survey them based on diagnostic criteria, you see that 1 in 8 have an alcohol use disorder. And then for women, it's 1 in 5. So when I say that depression is an occupational hazard, it's not just a recognition of the kind of life cycle and the very, very predictable times when we're going to see a spike in rates of depression. It's because I want to get at this, the root cause. So this is from OSHA. So they say that one of the root causes of workplace injuries, illnesses, and incidents is the failure to identify or recognize hazards that are present or that could have been anticipated. A critical element of any safety and health program is a proactive ongoing process to identify and assess such hazards. So you might look at this, and then you might look at this and say, wow, we have such a huge problem in our professional culture. We should make it mandatory maybe for people to go and see a therapist at different points in the training, certainly an intern year, or at least we should make it as easy as possible. There should be absolutely no barriers because this has really severe consequences for us. It has consequences for our patients, which we can talk about, right? So that's what we should do. But that is not what we do. In fact, quite the opposite. We make it very, very difficult for people to seek care. So this is a study that actually Colin West, who I know spoke to you guys a few years ago, did, looking at different licensing board requirements in different states to look at who was compliant with the Americans with Disabilities Act. And as you can see in the dark red are the states that were not compliant at either the initial screening or the renewal. Georgia, where I did my medical school training, actually just asks you, have you had any mental health treatment in the last 5 years? And that it gets very, very invasive. And it's really interesting because if you actually look at these licensing applications, they tend to much more discriminate against treatment as opposed to the actual diagnosis. So they're really stigmatizing the care-seeking behavior, which I think overlaps in really explosive ways with our general stance of neglecting ourselves. So I got this from the Licensing Board of Idaho, and I want to go through the questions with you guys, and I'd like your answers in the chat to what should I put down? So in the first question, it says, do you have a medical condition which in any way impairs or limits your ability to practice medicine with reasonable skill and safety? So I've told you that I have a history of depression. Should I say yes to this first question? Okay, so I see a couple of no's. Yeah, and I can tell you the benefit of after consulting with several lawyers, that is what I would put down. That's what I put down on similar questions. But I will also tell you that when I first started writing about this and I asked board members of the Massachusetts Medical Board if I should say yes or no, they did not know the answer. So the very people who are writing these questions don't necessarily know what they mean. So the second one, are you receiving ongoing treatment or participating in a monitoring program that reduces or eliminates the limitations or impairments caused by either your medical condition or use of alcohol, drugs, or other chemical substances? How about that one? Should I say, let's say I'm in therapy, which I am, and I probably will be forever because I find it really helpful professionally to process difficult patient encounters. Should I say yes to number 2? Yeah, Mo says no. All right, everybody's saying no. Honestly, guys, I don't know. I don't know. I would probably say no, but I think it's, I think probs no. Yeah, that's exactly how I feel, Andrea. Probs no. I think it's, and that's probably the legal term as well. I think it is very unclear. So I think what this really promotes is part of our culture that we're finding is even more problematic now in the pandemic, which is what I call the unprofessionalism of showing up, right? So we're taught that the worst thing that we can do is take a day off. And we're taught that beginning in medical school and then certainly through residency. And then in practice, you know, a lot of places don't even have necessarily have sick days. There's no coverage for you when you're out. I've had colleagues checking their inbox when they're in the hospital with pulmonary embolism, even though I've begged them to not do that. And I told them, I will check your inbox for you. So I think, you know, we have this attitude of always showing up, even when it's really not safe for us and it's not safe for our patients. So this was a study from 2015, very apropos for now, which showed that 95% of physicians reported that they agreed with the statement that showing up sick hurts patients. And yet 83% said that they had worked while sick. And the reasons that they gave were not wanting to let colleagues down, no coverage, and having few sick days. So you see there's that kind of internalized feeling, and then there's all these external factors which exacerbate it. So I want to read to you this an excerpt from this piece from Jeremy Topin, who is a physician in Chicago, and he wrote a really beautiful piece about this and the effect that this had on his family. So he says that, or he writes rather, in the middle of hearing about a patient newly admitted to the hospital, I received the page from my wife. I called her back expecting a generic morning update on the kids. Instead, when I picked up the phone, my wife said, I think I'm miscarrying. I called the chiefs and asked them to get someone to cover for me. Not long after, I was home and my wife sighed. We sat together, we talked, we cried. But as the hours passed, the notion that someone was covering for me, doing my work, seeing my patients, began to bother me. I became increasingly intense, and as the sun began to set, Becky turned to me and said, it's okay, go back to the hospital. I'll be all right. And I went back. My stomach still twists and knots when I think back to that moment. How could I have walked away? How did the culture of medicine lead a tired and emotionally exhausted young doctor to leave his wife, who had miscarried just a few hours earlier, to care for 2 young children on her own? So I want to share that with you because I think it's very difficult for us to think about what are the consequences of continuing to show up. And there are certainly consequences for us, and there's definitely consequences for the people we love. Sorry, this is a letter I got from someone a few years ago, and this is the first time I'm going to be sharing it with you, with anyone. And I did get his permission to share it with you today. So when we talk about depression, the reason that a lot of us are talking about depression at all, or even addressing the topic of physician mental illness, is the issue of physician suicide. And we've long known that physicians are at elevated risk of suicide, but I would posit that the risk of suicide is actually much higher than we know, because studying suicide is very, very difficult. If anybody's been involved in signing a death certificate for suicide, then you know that it will be, it has to be an incredibly clear case. And a lot of times physicians die by overdose, or they might jump off of buildings. And in those cases, and in the case of the young man that died in New York while I was there, it will sometimes be ruled an accident. But I've heard about a lot of, since we've had a couple of high profile suicides, but we have also a lot of suicides that we don't talk about. And this is one of them. So I got this letter from David Bell. He's the brother of Dr. Andrew Bell. Dr. Andrew Bell was a resident in Louisiana who took his life at the age of 37. So David wrote to me, "My brother was older for a trainee. He was 37 when he passed away. He got into drugs, dropped out of school, got sober, went back to school at the age of 30. He had 10 years sober before medical school. But the medical board didn't care about his redemption. He was subjected to random urine tests each week, which he had 30 minutes to submit on getting a text message. Missed the 30-minute deadline, failed the drug test. He told me he lived in fear of being in the middle of a life or death situation with a mother and a baby and feeling his phone buzz. We always worried about his mental health, but from where I sat, I thought, he made it through intern year. He was working too much, sure, and being pressured to submit inaccurate timesheets. But I guess I thought he had cleared the big hurdles and just needed to stick it out for a few more years. He was delivering babies, which he loved, and spending time with vulnerable patients who were desperately in need of the care he was providing, and that was really important to him. And then one day, he just didn't show up for work. Right after he died, researching the topic, I thought to myself, why didn't someone tell us the added risk he was taking on? A simple email or text to me, my mom, my dad, that said, "Thanks for serving as the emergency contact for Dr. Andrew Bell. We're excited to have him joining us at LSU Shreveport. Here are some things you should know." I don't know, but maybe that would have been enough. Maybe that would have been enough to trigger one more visit, one more phone call, make us more alert for warning signs, whatever we could have done. All of that to say that we know that suicide is an occupational hazard of medicine. It's an occupational hazard that our families may not be aware of. It's an occupational hazard that we need to start talking about. And yet these are the questions that we ask people. I mean, can you imagine a world in which you're filling out your license application and instead of stigmatizing treatment for alcohol use disorder or stigmatizing treatment for mental illness, instead they said, you're in a high-risk profession. You're going to be seeing a lot of trauma that your patients are experiencing. You're going to be in training programs where you're sleep deprived and isolated from your families. Here's some resources that you can access. We think it's really important that you get care whenever you need it. I like to imagine that kind of world. Finally, I want to tell you, I want to share with you this quote, which I think I found early on in the COVID crisis, and I think it really applies to us at all times, and it certainly applies to us right now. So this is from Aaron Mishler. He was an Ebola responder in 2014, and he wrote, "You may have someone screaming at you to come in because their mother is crashing. Do not go in without your PPE. Doing nothing may be the hardest thing that you've ever had to do in your life. Many doctors did run into help. Then they became infected, they infected others, and they died. They didn't help anyone after that. So in conclusion, as we've talked about depression, suicide, substance use, they're all occupational hazards of medicine. And unfortunately, stigma prevents us from seeking help for these incredibly common, dangerous, and devastating issues. We now are experiencing COVID-19, which is a separate occupational hazard, and certainly puts us at, interacts with the ways that we fail to take care of ourselves, and puts us at risk, and that in turn puts our patients at risk. But I really do believe that we can make this better. I think even in the brief time since I have been studying and talking about this issue, the culture of medicine has shifted so much. Even the fact that you guys are having this talk, the things that your medical society has done, the things that the residency program has done, these would be unthinkable 10 years ago. And I want to acknowledge the incredible work that so many people are doing. And this change is really coming from the bottom up with students and residents and people early in practice saying that this is no longer acceptable. So I will conclude again by sharing my email. Please feel free to reach out to me. And I just want to thank you guys so much for your attention. I'd be happy to answer any of your questions. So we'll do that for a little bit, and then we'll have you guys go into the breakout sessions after that.
Very good. Thank you, Dr. Poorman, for that very vulnerable address and being real sensitive to these difficult issues. We have a question from Dr. Desai. Are we medicalizing human suffering? I'm sure Dr. Desai could explain what he means by that, but maybe you understand that better than me. What do you think?
I do, and Dr. Desai, feel free to talk more if you want to get more into that. But yes, I mean, that's what we do as physicians, right? We medicalize human suffering. I think, you know, it's interesting. We have this discussion about addiction. So I'm currently an addiction medicine fellow, and we talk about what exactly is addiction? Is addiction really a medical disease? And that's certainly the framework that I like to use. But it's not just that, right? It's social isolation. For a lot of my patients, it's housing issues. It's you know, not having a strong support system. It's a lack of a sense of self, right? So it's a lot of different things. Medicalizing it for me helps me understand what my role is and how I can approach it. So this is the framework that I'm working with for what happens to us in training. And I think it's also important for us to not think that we're super special, right? We're human beings, and human beings respond in predictable ways to social isolation, to sleep deprivation and vicarious trauma. And so it makes sense that we have these high rates of mental illness.
Good. Dr. Desai, did you have any other reflections there that you want?
Hi. No, I hear you. I understand. I personally feel that we are medicalizing. To me, you know, we now start off our childhood with very little family around. Then we grow up with, you know, the culture and the family saying that taking care of yourself is not your top priority. Then, you know, you want to achieve things, and so you focus on A's and grades so that you can go into medical school. So you are set up for crashing even before you hit the school. Mm-hmm. Nobody, you know, the parents have not said that, listen, this is going to be an unfair world, and your mentors won't have time for you, and So, and then mentors obviously don't have time. So there is no family in the school. And then, so obviously the depression and anxiety gets worse. And then, you pick your line and you cross that line with PHQ-9 or whatever you have. And boom, you get a label. There are benefits to getting a label because then you'll get treatment and what have you. But anyway, my gut feeling is that we might be doing more harm than good. Anyway, I'll stop there.
I don't think that's an illegitimate viewpoint. I will say that I think I think you explained very well and very vividly one kind of path in medicine, but I will say there's a lot of diversity in where people come from into medical school. There's a lot of diversity in background and experiences. And certainly what I've noticed is that the people in my medical school had a lot more diversity in personality before we started medical training compared to after medical training. So I do think that that's important. And then, I think that the kind of ickiness that you're feeling and you're describing around the label, that it's, partially that we're trying to put human experience in a box, which is unfortunately what we do, right? But I think it's also you're internalizing the stigma that we get. So I think Mark McConnell said the Federal State Medical Board Organization has recommended that questions about mental health treatment be removed from state licensing applications. Has there been an improvement in state medical licensing applications since the 2015 data from Dr. West? Yes, so there has been an improvement. I think New Mexico and South Dakota recently got these questions removed, and they were some of the worst offenders. And the way that they were able to do that actually was, I think, through their local medical societies, working directly with the board. And it did take a long time and many, many meetings, because ultimately these questions are to minimize the risk to the board. So it took a while to settle on something that everybody could agree on, but they definitely did improve. So Andrea Christopher says, I didn't realize how much I bought into the US culture of medical training until I went to do a teaching elective in Australia and learned about how their training is structured. Can you tell me a little bit more about that? Because I don't have a ton of international experience with this.
What I was thinking about was, what I learned was in the residency training, this came up in one of our prior groups, but in the residency training in Australia, oftentimes the hours are capped at 40 hours. I remember asking, does anybody work overtime? And they said, yeah, and then you get paid for it because your supervisor signs off. And I said, oh, so then you work 80 hours? And they're like, oh, no, maybe 50 at max. And the duration of training is longer because you first start in your registrar year and things like that. So it's a lot longer because you sort of start your residency equivalent before you apply to your specialty. But your hours are significantly shorter per week, 40 to 50 per week. The salary is, at least at that time, 10, 11 years ago, was about $90,000 a year. So it was a much more livable salary, one would argue, than what current residents in the US face. And I was really fascinated by the idea that a longer training program, but in a more something that could actually be a little bit more affordable for people, to have that longer training. Whereas here it seemed like so much of the time pressure that makes residency so difficult, the pay cut, or not the pay cut, you're getting paid, but the time invested up front was really a different experience than what we have for the US. And so that's what got me wondering a little bit more about that.
Yeah, I mean, I do get messages from people in different countries, including Australia, and it just seems that I would love to do a comparison, because I think you're asking some really big questions, which is this the hours? Is it the compression of the medical training? Is it the salary issues? Is it our incredibly dysfunctional healthcare system, right? And I think, depression is a complex phenomenon. Suicide is a complex phenomenon. So it would be kind of hard to tease out, but it certainly would be really interesting. specifically with Australia, I get a lot of messages about bullying. So it seems like bullying and calling people out is well, I think it seems to be a general part of the culture. I get a little bit overwhelmed sometimes with the joking that I hear from Australians, what they consider to be humorous. But I think it kind of takes on a new level in the medical training. But yeah, but it would be really important to know. And then I will just say that, you know, every single place that I talk to, the issues are incredibly different. And I just encourage you guys, when you go into the breakout rooms, to really compassionately listen and think about how people's experiences might have been different from yours. Because, you know, this is one of the reasons why I'd like to do pre-interviews before I do talks. I've spoken at, you know, in 1 month, I spoke at Georgetown Medical School, and then I spoke at University of Miami-Jackson. And Georgetown Medical School, it was, you know, a lot of what Dr. Desai is talking about, like, you know, people who are very high achieving, they don't have history of failing. They get into medical school, it's the first time that they're really failing a test, or they're with people who are on their intellectual level and just as motivated as they are, and it can be really destabilizing for them. So that was a lot of what I got. People who didn't feel that fit that mold struggled in different ways. And then at University of Miami-Jackson, you know, it's a lot of people from other countries who have, you know, a ton of experience before they come here, but, you know, their family may be in Venezuela and they're sending the majority of their salary home. They can't always get in touch with their loved ones. And then on top of that, they're taking care of all of the traumas in South Florida, including a couple of mass shootings. So the concerns at the Georgetown Medical School and the concerns at University of Miami-Jackson were quite different. And they're all valid, but I think, you know, it's also important for us, you know, we do share a lot, but our individual experiences in training and then afterwards can be incredibly different.
Very good. Looks like we have a few more minutes for questions and answers. Does anybody else have any other questions in the last few minutes here of our Q&A time? And if you do, go ahead and unmute yourself, raise your hand, and we'll go ahead and let you speak just directly instead of typing that out.
Hi, Elizabeth. Thank you so much for your talk. It was excellent. So you said that you did go for some counseling after you recognized that you were having issues. Are you able to distill the factors, the things that you discussed with your counselor that you thought were particularly helpful?
Yeah, I mean, I think so. In residency, you know, I don't get into this too much because I don't have research to back it up. But I guess like my sense is that when people experience depression, that there is an overlay sometimes of paranoia because you are actually being evaluated all the time, and so that feeling of like. And our program was a small program, in many ways incredibly supportive, but I felt like I had been labeled a bad resident because I was struggling. So having some of that thought process, just kind of exploring that was really helpful. And then I kept going, and my first job out of residency, I was largely working with immigrant populations and then people with substance use issues. And those guys have a lot of trauma. And because I speak Spanish and Portuguese, so for a lot of, especially the immigrants, they were telling me about traumatic things that had happened in their lives or were actively happening, especially domestic violence. And I'm like a very spongy person, I like to say. Like, I'm sure many of you have experienced that. You'll walk into a room and a patient is manic and you suddenly kind of feel that energy. And so when they would go into these very detailed descriptions of the trauma, I would sort of internalize that in a way that I don't think medical culture really teaches us how to process, right? We're just supposed to be kind of like that listening ear and then go home and switch gears. I don't think that's very natural. It's something, interestingly, that therapists and psychiatrists work a really long time to learn, and then they continue to be in supervision. So that for me has been the kind of continued role of therapy.
In many ways, I mean, I think it's a great model that people that are therapists have to continue therapy. Do you suggest that we should be doing something? You hinted at the fact that this should be normalized.
Yeah.
Yeah.
Yeah, I mean, in my ideal world, every physician would go to therapy, at least periodically. One, because the rates are so high for us, and two, we see a lot of traumatic shit right, all the time.
Yeah.
And I don't think it's a natural thing for us to assume that that's not going to affect us, and that that's not going to affect the way that we then approach other patients, right? You see it all the time. The frequent flyer comes into the hospital, right? And we kind of approach them with an attitude of hostility. But the attitude of hostility is because we feel like we can't help them, right? And so these are things that if you are able to kind of talk it through with somebody in a place where you feel safe, then that's something that you can improve. And that can be really important for somebody who needs you.
Mm-hmm.
Sharon asked, oh, there's a German word in here. Do you believe there is some schadenfreude amongst medical professionals? Like others perceive medical illness as a sign of weakness. Also, do you believe medical professions have the same privacy within their peer groups as compared to other professions? It seems ironic those associated and advocating for physician well-being sometimes struggle to stay in their lane. So I think, yes, I think that there's this idea that we have to be perfect. There's this idea that having experienced illness in some ways is going to make us less worthy as physicians. When, I mean, you think about the illnesses that you've actually experienced and the way that you're able to counsel, like, you know, the whole course, right? You know, the causes, you know, the treatment, you know, how long it takes to get better. You know that in a way, in a visceral way, better than anything you're going to be able to look into a textbook. So I think, you know, for me, having actually experienced depression makes me so much better at counseling people. I occasionally will disclose to people if I sense that they're really feeling a lot of shame about seeking care. I especially get that from young men or maybe, you know, people just doesn't have a lot of experience with medical care. And, you know, I'm really able to tell them, you know, it took me a while to find the right medication. It took me a while to find the right therapist. I got a lot better. I really feel like you're going to get a lot better. And I'm very proud that I'm able to do that for people. Mo says, okay.
Oh, I was saying thank you. You know, I went to a counselor during residency, and I remember just having that as an opportunity to process all the stuff and there not being any diagnosis. And I think that it gives you a space where you can go and leave that, so you don't take it home, or, you know, you can associate in other settings without processing that. It kind of gives you a place where you can go.
Mm-hmm.
I don't know, I found it incredibly beneficial. During one of my friends, a fellow classmate, had gone and had the same experience. So I think that it would be a good opportunity for people. Although I do have concerns, and I have had personal experience here within our community of there being conflicts of interest and lacking privacy. So I feel like we have a lot of room here within our community for improvement. And I understand other people's resistance because of that.
Yeah, I think that that's really important. I mean, you know, in my case, you know, my therapist's office was in a place where my privacy could not be protected, right? The first one that I went to see. And I think there's a lot of subtle ways that our privacy can be violated. We're also just like very used to just chatting with each other about our patients. And sometimes we might do that instinctively in a casual way about our colleagues in a way that's not appropriate. So I think I'm glad you brought up the privacy issue. I think that's huge, and it's very tricky and complicated. And I will say, like, if you're in the well-being space and you're not thinking about a person's privacy all the time and making the rules of what you will share and what you won't share very, very clear, that it's very likely that you're going to run into a problem. I see from Mo says that I believe psychiatry residency training has required therapy for the residents. I'm not sure if there are any other specialties where it is required. I wonder if that's something that the educational community should push for. So it is true that traditionally psychiatry residency, sorry, somebody's talking? Okay, it is true, as Mo says, that traditionally psychiatry residency does recommend that everybody go to therapy. It's not uniform how that's actually done. In many cases, it's just a recommendation. There's not a clear path to actually making that happen, as opposed to people who are in counseling programs tend to have actually counseling for themselves as part of their training process. But I think that's true that psychiatry does normalize more access to therapy, normalizes more concerns about being labeled with mental illness. I absolutely think that this should be a requirement of training programs. So I really like the idea of opt-out therapy and opt-out therapy on an ongoing basis through residency programs for everybody. A couple of programs do that. I think one of the Kaiser programs in California recently started doing that on a monthly basis for the residents. So it's a scheduled appointment, but the residents can choose to go or not to go, but they don't tell anybody. So that's, so they're doing a lot of things to protect the privacy. And then Stanford surgery program, actually, they lost one of their chief residents to suicide. And after debriefing sessions, and they also have some opt-out therapy appointments as well. Mark McConnell says, do you think that physician suicide problem has worsened over the years? I trained before work hours restriction, put in long hours, but didn't really hear much about resident suicide, except for the occasional overdose. More recently, in the era of resident work hour restrictions, there seem to be more suicides or awareness of suicides. Has the rate of physician suicide over time increased? Or was it the same? And we were just protected from their events. So I will say that the short answer is we don't know. People have not been studying this in a systematic fashion until pretty recently. And even now there's huge issues with the data. But we do know that, a lot of suicides are never called suicides. And, in addition to people realizing for the first time that they may be depressed when they're talking to me, I get a lot of physicians telling me about a suicide that they experienced that they weren't allowed to talk about. And telling me, even in like a conference setting where we've just met, telling me that I'm the first person that they're telling about, this loss that they had. So I think there's probably a lot of people that we've lost to suicide that only a small circle know about, or people may have suspected, but it's not necessarily called that. So that's one. So, but rates of depression certainly are going up. And the work hours is a very tricky issue, but it seems that overall residents are not actually working fewer hours than they were 30 years ago. It's just that the hours are kind of shifted around. And the number of tasks, the number of patients, the turnover of patients, the complexity of the patients has increased dramatically. So what we have is kind of work compression. Sarai says, compound the stigma for physician to reach for help for minority groups when they receive bias and discrimination, often in silence during training, and data on that. Yes. Let's see, I actually have a slide on this. Let's see here. Yeah, so I'm really glad you asked this question. I had so many things that I wanted to talk to you guys about, but this is actually looking at bias by gender, so that physicians experience from patients. So that's separate than the issue that you asked about, Sarai, about bias from other physicians. I mean, I will say there was a great study of Grand Rounds presentations that men were introduced as doctor 100% of the time, and women were introduced by their first name 50% of the time. So that's even in the very formal setting of Grand Rounds. But this year you'll see that women are much more likely to experience any bias, that they're more likely to hear negative comments about their gender, their age, their weight. And that this is looking at physicians by race, and you'll see that for bias comments about their ethnicity or national origin, that Asian physicians get a lot of negative comments, Latino physicians, African American physicians, and then regarding race, it's a huge number of African American physicians get negative comments about their race compared to a very, very small number of white physicians. So yeah, so definitely that kind of added layer, and that just kind of plays into the thing that I was talking about, that people's experiences are deeply, deeply different. And Steve, feel free to cut me off anytime. So I don't know if you guys.
That's a great discussion. But I think that there's more discussion to be had, and I would love for everybody to have the chance to do that. So yeah, let's do this. We're gonna go to breakout rooms here soon, and I'm gonna go ahead and take back the screen. Thank you again for the presentation and fielding those questions. And what I wanna do before we go to breakout rooms, because I know everyone's gotta get their cameras ready if you haven't got that ready and on, just real quickly wanna blow through some of the resources that we have at Ada County Medical Society, the Physician Vitality Program. I hope everybody has heard about this already. We provide 8 counseling appointments per year, no charge. You make your own appointment directly with a counselor on our website, and unless somebody tells me, I don't even know who utilized it, because our therapists verify membership eligibility on their own. In fact, we have a couple of our therapists on tonight, Becky Marks and Jennifer Ritter, and there may be one more that have come on just to join us, and they'll be in their own breakout room, but great resources there. You can see over the past 4 years that we've had this program that we continue to see growth all the way through the end of June. We had already seen as many appointments used as in all of last year. So your peers are using this program. Don't be afraid to use it. Since we've converted to telehealth, you can see that we have had a huge spike, and 92% is being kept by telehealth. If you're on the medical staff of St. Luke's or St. Alphonsus, we have 2 peer-to-peer programs, each under those peer review processes, and those are private and confidential and not available to discovery. So those are really important resources if you're on the med staffs. We have a website that's got a lot of resources that's organized around the National Charter on Physician Wellbeing. These guiding principles and societal commitments are listed at physicianvitality.org. And we really want to elevate a new aspirational standard for our medical community. And you can read about that, as well as some of the resources, not just personal resilience resources, but how do we change our systems? How do we create better environments for doctors to work in? I want to talk a little bit about some of the things Dr. Roman has done. She has an action collaborative around prior authorization burdens, has been working on that for the past couple of years. But that's not all. A couple of years ago, she organized a conference that was held at the Jump Building. It had some great speakers there. She continues to host an online discussion group for both physicians and med students once a week, co-hosts mindfulness and meditation groups with Dr. Abhilash Desai. Both of them are on this call. So I thank them. They really are the 2 doctors who've leaned so heavily into this. And I just want to call them out as exemplary in that regard. And then we have our book club that I mentioned before coming up. It's a great opportunity to connect with your colleagues in an informal setting and build relationships with each other, since we have been so isolated during this time. Finally, National Physician Suicide Awareness Day. If you go to facebook.com, AA Suicidology, there's some great recordings from this past month's Suicide Awareness Day Facebook flurry. The 11 o'clock, the first recording of the day on shame and medicine by Will Bynum. Excellent presentation. I highly recommend you view that. You can see that at facebook.com. So with that, please prepare your cameras and your microphone. If you have dogs or children in the background, you can kennel them both however you wish. Just a slight joke, but that's okay. Glad to get a little chuckle there. And we're going to go ahead and put you in a breakout rooms. You do need to press join when you get that prompt on your screen. So away you go. Looks like we got most everybody back in. So we're going to go ahead and field some of the feedback on the question that we answered. I'm going to go ahead and ask Dr. Hagman to have her room or the scribe in her room report out. So if that was you, go ahead and unmute yourself and share with us what you guys talked about. Obviously, I want to respect privacy and confidentiality. If something was shared, that would be appropriate to share it with everybody else. Who from that room wants to report on that?
Steve, thank you for the grand opportunity to be the first group to report out. We are honored and delighted. Nobody actually knows who else was in our group, which makes the anonymity like super cool, because it could have been anyone who wasn't in your group other than me, who was in my group. So there we go. Gentlemen and women, we may be anonymous. So the anonymous group, we talked a bit about how some people did well in residency without any troubles, and then found when they were, after they had graduated from residency, that was the time. So that made sort of relating to some of the stories that Dr. Poorman gave was sort of a different twist on it. We had members of the group who have made it through medical school and residency and perhaps nearing retirement, who now have children who are in medical school, who they worry about and hope that their situation goes well. And then some of us who believe we may be in the percentage who didn't have serious issues with depression, worrying about those around us and how we can help.
Yeah, thank you so much. First, I just want to thank you, Mo, for also mentioning in the chat that you had accessed this resource, the Physician Vitality resource, and had a good experience with that. Everything that I do and talk to you about and put in these slides is much less powerful than hearing from your colleagues. I went to this person, it was safe, it was helpful. So that's the kind of leadership that you guys need, and that I really respect, and I'm so touched that you shared that. I absolutely agree with you that the first couple of years out of residency seem to be an incredibly high risk time. People are losing the support structure up the residency program. They're losing a group of colleagues that they may feel close to, or at least have been bonded with over some difficult experiences or some great experiences. And a lot of the suicides that I've heard about happen in those first 2 years, either in practice in the community or in fellowship. There's also some other times where people are at elevated risk, and maybe I'll continue the chart based on the kind of hundreds of interviews that I've done over time. But certainly malpractice is a huge risk, and the way that we approach malpractice as like a personal shame, and you're not allowed to talk about it, is really, really traumatic and painful for people going through it. And then after an adverse event that maybe doesn't even involve malpractice, but just really feeling like you did something wrong, or even if you didn't do something wrong, the patient died. Those are really high risk times. And then finally, retirement is a really high risk time for people as well. If you get all of your pleasure and identity from your work, I have actually lost personally a colleague to suicide at that time as he was retiring. He was diagnosed with a medical illness, didn't feel like he could work anymore, and because he couldn't work anymore, didn't feel like his life had meaning. And so unfortunately we did lose him. So I think, those are definitely important points. So we know a lot about what happens in residency because there's some uniformity to the process. It's been studied. But what happens throughout our practice, we continue to have these high risk times. And in terms of being concerned about a colleague, I think, one of the best things that you can do is just honestly ask them, how are you, at a time when you have the emotional space to hear it and they have the emotional space to tell you. So please don't ask them as they're about to walk in to see a patient. Please ask them, at a time when it's safe for the both of you, where their privacy can be protected, and they feel like that they can share that with you. I think that's an incredible thing to do. I mean, that's what somebody did for me. I think it's very possible I would have quit medicine. It's possible that, maybe these fleeting thoughts of like just wishing that everything would end would have become more serious for me. But they didn't, because somebody said, hey, you seem to be struggling. Is there anything I can do? And she really meant it.
Very good. Let's go next to Dr. Christopher's room. And Dr. Christopher, I understand that you're going to introduce your scribe from your room.
We were the team with all of the students, and the students already had a brilliant idea, better than what I offered, which was who's going to be our scribe for all sessions, and we're going to rotate. So this time we have Meredith, who is going to be sharing from our group.
Hello, I'm an OS too at the Idaho College of Osteopathic Medicine, and some of the things that we talked about in our group included particularly things that did not work well for us. A lot of us kind of focused in on our first semester of medical school. We came in with so much liveliness and vigor, and we felt like we were prepared for the difficulty, but not necessarily prepared for the emotional roller coaster that was coming in, and the compounded anxiety in terms of trying to balance coursework with having these new emotional stresses for most of us just ended up being so overwhelming. Mm-hmm. Some of the things that we found helpful were just not putting a mask on and just naming what we were feeling, accepting what we were feeling, trying to find a support system at our school with other students, just being able to talk about those things. And one of our other participants mentioned that how some of the issues of that actually ended up compounding on each other, because a lot of the students not wanting to admit what they were experiencing ended up isolating themselves. We isolated ourselves from each other. And so we talked about that as well as one of our other participants found that going on runs was it developed into her own outlet. So she really found a new positive behavior to help deal with her own stress. And so those are the types of things that we talked about.
Awesome.
Very good. All right, we're going to go next to Dr. Baruch, Amy Baruch, who's on our board of directors. Do you have a scribe, or are you going to report out? There you go.
Well, I have a contingent from the NAMPA Family Practice Residency if they would like to chime in. Otherwise, I'm happy to just talk about our discussion. Are you guys interested in kind of summarizing? I don't know if they're still on.
Let's see. No, I'm seeing a head no.
No. I'll start
off. Please go right ahead, Dr. Baruch.
Sure. I'm going to start off with something super positive, which was a big plug for the Physician Vitality Program and how much it is greatly appreciated and utilized by the residents. So I think that's the wonderful endorsement. So thank you. And I think that's one of the greatest strengths that we have for our community. We talked about some of the ongoing issues or things that may be a source of stress for residents. I think system problems continue to be an issue, documentation being one of the major ones, and that comes up over and over again. But we did reflect on the situation here as it compares to maybe some programs on the East Coast where there seems to be maybe even a complete disregard in some programs for some of the restrictions on the number of hours residents are supposed to be working. And we just started to talk about how that would probably add another layer of stress or a feeling of a lack of control, because you are knowingly being subjected to something that apparently is illegal, right? But don't feel empowered to be able to speak up regarding that. You don't want to be the whistleblower. Again, you're getting stigmatized, right, if you say anything about it. So I almost think that would be a double whammy. It's bad enough that you'd be working in excess to the point of exhaustion, but then there's something that's there to protect you, and despite that, it's not being carried out. And so you just feel less empowered than you would otherwise. So I'm glad that's not as big of an issue here, but it's important to reflect and compare how we are doing compared to other programs. So.
Good, thanks for that contribution. Our last room to report out will be Dr. Ambert Pompey.
Hi, so we got a little distracted, but we got back to talking about the topic. Some of it was that some of us in the room happened to be doing telehealth before telehealth became cool. So we talked about how a lot of people were hiding it and not really talking about it, and the stress of the transition for those that did it for the first time after in the room. So that also added to the stress. So just putting that out there. Our official reporter was Dr. Blake, but like I said, we didn't really have a lot of time to talk about that.
Very
Yeah,
good.
and I've learned a lot from Sarai about telehealth via Twitter. So thank you so much, because that really sucked for me too. I want to just touch a little bit on some of the things that you guys brought up. So I adapted this from Colin West, and I added a little bit as well in here, but I love the way that he kind of presented this solutions that people have tried and actually have shown to make a difference in some of these outcomes for physicians. And talking about, we have the driver, and then we have the organizational solutions, and then we have the individual solutions. So I'm happy to share that with you guys afterwards, but certainly study after study shows that organizational solutions make a much bigger difference than individual solutions do. They're certainly harder to do, but I think the other thing is that organizational solutions also show us as people working for an institution that they actually mean it, and that they're willing to put their money where their mouth is. I also want to talk about the medical students we're talking about with the emotional roller coaster. I think that's absolutely right. I think, you know, a lot of times people have been successful in medicine, can be a little bit detached from their emotions. So they may not be able to prepare you for that. You know, certainly they came through at a time when it was much less normalized to be talking about these things. So there's definitely a generational clash. One thing that you guys didn't bring up, but I'm really noticing a lot with the medical students I'm working with, is that not being able to be with each other is such a huge, profound loss, right? So a lot of, you may not be in like actual therapy, but the kind of casual talking through things, that, you know, sense of like, are we really gonna like memorize all these nerves and remember them forever? And you're not gonna remember them, I can just tell you now. You know, those kind of like little normalizing things are really hard to do virtually. So I am incredibly concerned about medical students right now. You're doing something that nobody has ever done, which is the virtual medical school. And it certainly has a lot of consequences. The other thing, I'm sorry, I call everybody by their first name, but Amy mentioned that the issue of people working more hours and then lying about that. Yes, there's actually studies to show that surgeons particularly lie, I think 75%, so that they lie regularly about the number of hours that they work, that they regularly work more than 100 hours. And then in programs with lots of IMGs, I've also noticed that that's a very common thing to happen, because if you're an international medical graduate, you're here on a residency, on a visa in the residency. If you complain and you're found out, or your program actually gets sanctioned, you may lose your visa and be deported. So there's a lot of asymmetrical power, and that's kind of just the tip of the iceberg of some of the abuses. Yeah, so that's that. So thank you guys so much for sharing. You've really touched on a lot of really important issues, and I really appreciate your participation.
Good. Well, let's go to our next question, which is thinking of the difficult experiences you shared. What types of things did your employer or institution that supported you or made matters worse? And again, by the end of this, we're driving towards solutions. So this is an opportunity to identify things that are working and things that maybe aren't working, because ultimately we're going to ask the question, what do we need to do next? So let's go back to breakout rooms and keep the discussion going. Welcome back, everybody. I know that was too short a time to actually have a decent conversation, but part of the goal of this is just to start the conversation so that you can take it back to your workplace. Let's go ahead and report out some of the ideas that you have. I know we'd probably like to talk about what did or didn't work, but we really don't have much time, and I want to focus on solutions. So let's start with Dr. Christopher's room this time and ask what kind of ideas or solutions you guys came up with that can be implemented at your institution or workplace, or that Ada County Medical Society can work on.
Okay, so we mostly talked about a lot of positives that we see, but one thing that we could work on in our school setting is some students fear that they would look weak, or sometimes they would fear retaliation if they were to come forward with different issues. So that's something that we can work on. We didn't really come up with maybe solid solutions, but that seed is planted, that idea is there.
Very good. And that's the problem to address. So how to address it is always the question, right? Good. Thanks for sharing, Tegan. All right. How about Dr. Hagman's room? Do you guys want to go ahead and share out?
My group chose to remain anonymous still, so I will be the leader still for the group that has anonymity. We thought this was a very simple problem with a very straightforward solution. We all need capes, superhero capes.
No capes.
Right, exactly. No, my group didn't say anything about capes. I'm going off script. So we talked a bit about the Physician Vitality Program, which has already been mentioned. It's been a tremendous help. We talked a bit about how the medical society has gotten bigger, which is a good thing, but has taken away some of the intimacy of maybe when it was a smaller group of individuals. We don't necessarily have good solutions for how to make it feel smaller, and recognize that Steve and the ACMS folks do a lot of activities to give us opportunities to meet each other. So maybe it's, the people here tonight making a point of saying, I'm going to reach out and make an effort to know more people in the Ada County Medical Society, to try to make the community seem smaller. And we also talked a little bit, with no firm solutions, about can some of us who've been through the ringer be of help to people who are in transition, whether that's medical students going to residence, residents going to practice, people going from big practices to small practices, those sorts of things. And I also want to recognize that the Medical Society already does do a good job with mentorship for residents when they move into the county, and those sorts of things. So really, Steve, we just took all of your ideas, thought they were great, and thought we needed to participate more. So maybe we need to participate more.
No, I'm here. I heard an idea. It's called the transition team, and we loaded up with people who want to help people through certain career transitions and who are available. So we can take that one and run with it. Very good. Thanks for sharing that. How about Dr. Baruch? Would you go ahead and share?
Sure. On the positive side, it sounds like communication between residents and their supervising physicians is very open. They gave an example of switching some of their shifts, some of which were very long, and sort of dividing them up, splitting the time. That really improved the quality of their experience and education, and seems to be very fluid. So I thought that was very positive. It was great to hear that. I'm willing to jump in on this one if you want. Yeah, why don't you go ahead? I was like, how much do I say? Go ahead, Carla.
I derailed the conversation of an absolute worst case scenario from another state. And I think the upshot of it is communication and sort of understanding, I think all of the things that Elisabeth talked about with stigmatization and how our regulatory bodies work, and the threading the needle between weeding out problematic things versus supporting the vast majority of folks who need help. And you know, there was sort of a worst case scenario about that I think needs to kind of percolate to the surface. And I think that there's sort of, you know, the best thing that I think I heard from Elisabeth is that there's, you know, Pamela Weibel is doing a whole bunch of work on physician suicide. And this is all sort of percolating up, and the data is becoming clear, and the Dr. Death podcasts and the, you know, scenarios are sort of percolating up, and it helps when you find yourself in a really bad situation. And I think that's a good summary of the latter half.
Mm-hmm.
Good. All right, and then let's go to Dr. Ambert Pompey.
All right, so just to summarize, because we all work in very different environments, just to make some broad suggestions to make sure that these, you know, we can always position physicians in leadership positions where they can make sure that these types of, you know, protections and programs are put in place. Make sure that there's physicians in leadership, just as a broad view of things, making sure that these programs that are at the community level to support the community level have you know, providers that if they wear multiple hats, then there can be some potential conflict of interest. So making sure that all of these things are addressed. But most importantly, I think what we talked about is just making sure that the people, all these programs help people feel supported and secured, and you know, that their privacy is there. So regardless of where people work or where they are.
Great. Dr. Poorman, I'm going to let you have the last word of the evening. And as you do, I want to point out to people that we've posted a evaluation. And if everyone has a chance to take a look at that, we would sure appreciate your feedback on that. We'll post that in the chat. But Dr. Poorman, you want to send us out with any final thoughts here?
Yeah, well, I just want to, again, thank all of you guys, and especially everybody who helped plan this event. Planning things virtually is actually a lot more complicated than planning things in person. So thank you for your creativity and flexibility with that. And thank you, everybody, for participating in the breakout rooms. I think it's really important. I think I just want to address two things really quickly. One, the issue of reporting things that you're concerned about. And the second thing about the worst case scenario. So it's really, really hard to know how to address something that you think is wrong in your workplace. Blowback is real. You know, the response is not always what we would hope. And that's where I think mentorship is so important, to really understanding, is this really something that, you know, happened because of an individual? Should it have been done differently? What's the best way to approach this and make change? So I think it's really great to be in a group like this where you have people from different fields, different levels of experience. People have different backgrounds. So I would just continue to you know, reach out for that. I have reported a lot of things in my time, and I have experienced a lot of issues because of that. But I'm not sorry ever to have done it. And I think I've gotten smarter and more strategic about how I do it. But ultimately, if I can't go home and sleep at night, then I'm gonna say something. In terms of the worst case scenario, that's a very real thing. And I just want to tell you guys a quick story. I spoke at a residency program that shall not be named, that had a large number of international medical graduates, and found out that one of the residents who was about to graduate reported some safety violations and some workplace violations. And that person had their visa threatened. And I was talking to this person, and I knew he was at a place now where he had access to great care and great support that I really trusted and had had great experiences with in terms of helping other people get connected. And that they had come back and told me that they really felt, you know, supported, that their privacy was protected. And he said to me, no way. There's no way I'm going to access that because his experience had been so terrible at his institution. So that certainly does have kind of lasting consequences. And I think it's good to also remember that people may have had those really negative experiences in their own institution. And I think one of the big strengths that you guys have in Boise is that small town feel of everybody being connected in multiple ways, that you have the opportunity to really decide together to change the culture in really meaningful ways.
That is totally true. We love living here, and you are welcome to come join us in Idaho as soon as you finish your fellowship. We can use some more addiction specialists. So, absolutely.
Awesome. As soon as I get my vaccine, I'm on my way.
Hey, we got low numbers right now, kind of. And thank you all for joining us. I sure appreciate all that you guys have to offer. Do fill out the evaluation. Thank you to St. Luke's once again for their sponsorship of tonight, and hope to see you all at a future event, online or in person, whenever the case may be. Good night and good luck.
Thank you.